The next speaker is Dr. Bhagabat NAYAK.
So respected
What do you start?
faculty and so thank you OSS and All India Open Society APO for giving this opportunity. My topic is management outcome of white cataract based on new biomarkers and ultrasonography. So I'll quickly go to this just history. As you know, this gentleman, we are celebrating 75 years of IOL implantation, and our journey went through like this: couching, ICC, ECC, phaco, and flax. But still, in our country or in this part of world, MSc, HMSc white cataract still the show, and presented with phacomorphic glaucoma, phacolytic glaucoma, difficulties in capsulation, phacoemulsification, longer surgery time in terms of CD, more chance of complication in terms of vitreous loss, general dialysis damage, etc. So you can see in this video that what we do is generally we all do in intervention cataract, we aspirate sometimes when the fluid egresses, and after that we can okay. So we want to do a good capsulorhexis. स्पीड नहीं हो रहा है. So and multiple capsulorhexis we have to do because in fear of losing the capsule. So after this then you can do your routine cataract surgery. But sometimes after putting the nick on the anticapsule, when there is a fluid doesn't come, and you may go to periphery, there may be some irregular fluid component in the mid periphery, and it can lead to arginal flux. And then after so many, there are, according to your experience, you will manage this case. So my point is, why we thought for this? You can see the right side. My cursor is not working. The right side, the old photo. That was this photo is of from RP Center in 2008-9 when I was posted in ultrasonography room. I found these things like you can see that there are two signs, two peaks. One corresponding to the PC, that towards vitreous. Another is corresponding to the posterior lens, posterior nucleus. Sorry, posterior part of the lens, that nucleus, and in between that anechoic area is the fluid that means accumulated in the posterior compartment of the lens. So that's why there is a two peak, and here you can see that this is our latest from the AIOS Bhubaneswar. That photo is only there is a cataract. You can see that, but only there is one peak corresponding to the PC. So that I was thinking for this for 10 to 12 years, and then we did some work here. You can see this first video. Here is the intervention cataract. I want to say that in all cataract you will not find. Here you can see that if you see the axial, that means ultrasonography, you can see only one peak is there, corresponding to the PC. Here you can see, here is the intervention cataract, white cataract. You can see there is two peaks corresponding to the PC and posterior part of the nucleus. So finding on this, we did our work to see the double peak sign in pre of ultrasonography and management outcome. And we found 56% from July to December 2023 in a prospective study, and ultrasonography done in all cases. 6% high IOP in range of 30-34 that was managed with mannitol and all the anti-glaucoma drugs. In this flowchart you can see that out of on ultrasonography 24% had double peak sign, 32 had not. So among the 24%, 12% we given mannitol because we wanted to manage what we can do to reduce the posterior thrust, that means vitreous upthrust or posterior interlenticular pressure we had to accommodate, so that when we enter the anterior capsule, that means the lens will not that come forward, so that in that way can we that means reduce the that means complications. So out of this 0 out of 12 no capsule run away, 6 out of 12 without mannitol group, that 50% special capsule run away, and who had no double peak sign, 2 out of 32, only 6.25% had with capsule run away. That is statistically significant. So you can see this, that means that double peak sign has that run away. And so we did our work further. In young adult case, you can see that there is a clear crystalline lens, anterior, posterior, both the lens capsule are seen, but there is one peak sign in posterior compartment. Here you can see that is the difference is, we measured the difference between the two peaks, that is 1.14 millimeter, here is 0.78 millimeter. Why I am showing this? We did the distance between the two peaks, and here you can see the 1.99 millimeter. And here you can see that there is irregular, that means anterior cortex fluid In between the lower side, there is a only cortical matter is there, and there is a large gap in between the anterior cortex. The difference is 1.42 millimeter in 2 peak sign. So what we found that more than 1.2 millimeter gap in the 2 peak sign, we are having more, that means complication, more chance of capsule run away. So important points: pre-op ultrasonography focusing on PC and counseling. I am saying that on the that means above that means for the generalized way, and the rexis forceps microforceps scissors should be ready and on standby. Pre-op monitor works in reducing the upthrust as in our project. Aspiration of cortical metal by needle cannula or irrigation aspiration. Very small rexis if you are making. After that do IA and you can enlarge the rexis later. Some people do phacoaspiration of central capsule and cortex, and some do also limited anterior partial vitretum, but that is a blind procedure, but some it is written in literature. And backup IOL is must, like 3-piece and rigid also. So our work has been that means we have got that copyright from the intellectual property of India, and we recently published in as a innovation in IGO. So this is our team. So thank you for kind listening.
Thank you, Dr. Bhagavat. Dr. Namrata wants to ask you a question.
We just wanted to know whether any internal and external validation is done for this new site.
Okay. In our institution, some faculty and senior resident already they trained. They are getting the sign because the while they're doing it is very important. And there's internal validation almost done. For external validity, one institute from the Nepal, they have read the journal. They have called me, that WhatsApp me, and I have sent their video. They are trying to collaborate with the project with us for the external validity. We are taking that opportunity for the external validity.
Bhagavat, I cannot resist this question. Intumescence is of two types.
Sir.
Anterior intumescence and posterior intumescence.
Yes, sir.
What you're looking at with the ultrasonography here essentially speaks about the posterior intumescence.
Yes, sir.
If the nucleus is very large,
Sir.
they produces an equatorial block,
Yes,
and
sir.
the anterior and the posterior intumescences are not necessarily communicating with one
Not-
another
yes,
if there is an equatorial block, which means in the presence of the posterior intumescence,
Sir.
the anterior part may be absolutely fine and you might not have a runaway rexis, and the reverse is even more dangerous. In the absence of this double peak sign, you can never be sure that the rexis will not run away. How have you looked at this? I mean, is it something that you have?
What you are saying that is right. So we have to work on further, because you are saying that if there is no communication, then
I'm saying they're
this
independent
concept-
entities.
Yes, independent entity. But you are saying that part of some of the intubation cataract, no? Yeah.
Of course
yeah,
it is.
Yeah,
Nothing
yeah,
can
yeah,
be
yeah,
applied
yeah,
as a
it can
rule.
be, but we will work on that, because we cannot know, no? We cannot know. So this is one of the method we are trying. But how we can know that whether the lens is so large? Because in that fluid, if you see the anterior fluid pockets, in most of the cases there is a anterior fluid pocket, but that doesn't mean that posterior compartment has that type of fluid.
That's exactly what I'm
yes,
saying.
Yes, I'm saying that. So that's why out of 56%, 32% has no double peak signs. But among that, 3% had run away. So I am saying that majority of the cases where we got the double peak sign, there is chance of. And
You
even
should be careful.
Again, that is the difference between the double peak sign that we are working further. So
I think you can try reversal biometry where you can get double peak in the anterior capsule and double peak in the posterior capsule also to know.
sir, yes,
This is
immersion.
B scan.
B-scan
B-scan
is more,
videos.
that means with involved with A-scan, no? So that is more.
You cannot get B-scan anterior capsular spikes.
That is what.
that
That's
is
the reason why he
that-
is unable to. He's getting the double peak on the posterior part.
that is difficult in B-scan.
That is
All
because
said and
some,
done,
some transparent material is there in between those two peaks lines.
Sir?
Some transparent material is there in between.
Fluid cortex.
Fluid cortex.
Yeah, yeah.
Fluid. Oh, so
And the upthrust is more if the gap is more. Very
Yeah.
rightly pointed out by him. But nothing, end of the day, nothing beats an ASOCT to know whether or not the
But sir,
floccular cortex is.
but the ASOCT, yes, there was a article I have placed on that innovation article also. But ASOCT they show na, that fluid pockets are in various fluid pockets. And second thing, ASOCT that it is
Cost.
a very
expensive.
expensive. It is all for available.
I said nothing beats. I didn't say
Yeah,
about cost.
beats no beats, but that double peak sign will not get that accurate. I have you will go through that article. I have written that also.
Bhagavat, as your number goes up, obviously.
Yes, sir. Yes, sir. Yes, sir. It is in initial way.
Okay,
Certainly, it
thank
is
you.
a nice observation.
Thank you, Dr. Bhagavat.
It's a nice observation because we are
Thank
seeing
you.
intermittent cataract since long, but we have never thought of doing this and analyzing in this way.
Sir, actually, I tried getting that double peak sign, but could you please elicit like how much
Yeah.
gain settings and
Jaydev SR or SR is here?
as well as the
Yeah.
with
Okay.
scan?
Yeah, we can take this
We can
question
let-
later
we
on,
can take
after
it
the
later
section
on.
is over maybe.
Oh, that's why I had made video. I will send to you. And the proper axial scan, once you focus on the PC, no?
Yeah.
Maximum, most of the time, ophthalmologists, they don't go to the ultrasound.
Okay, Dr. Bhagavat, we
Yeah,
can take
later.
it later on.
Later on.
Okay, thank you so much.